Hi everybody, this is chapter 31 in your Wong book, The Child with Musculoskeletal or Articular Dysfunction. The physiological effects of immobilization on children are much like that of adults. These kiddos are going to have decreased muscle strength, tone, and endurance, atrophy, a loss of joint mobility, including the possibility of joint contractures, and that all is for the muscular system. In the skeletal system, the effects of immobilization will include bone demineralization, and what happens there is increased calcium leaves the bone, which causes osteopenia, and that is demineralization. And this can predispose these kiddos to pathologic fractures. From a metabolism perspective, these kiddos are going to have a decreased metabolic rate, hypercalcemia, and decreased production of stress hormones. Some reasons that a child might be immobilized would be if they are in traction, if they've had spinal fusion, or if they're in a hip spike-up brace, and we'll talk more about that a little bit later. Continuing with the physiological effects of immobilization from a cardiovascular standpoint, these kids are going to have decreased efficiency of their orthostatic neurovascular reflexes, diminished vasopressor mechanism, altered distribution of blood volume, venous stasis, and dependent edema. So for number one, the decreased efficiency of their orthostatic neurovascular reflexes, this gives them the inability to adapt to an upright position. They can also have orthostatic hypotension. With syncope, they can have decreased cerebral blood flow and tachycardia. They can have a decreased cardiac output. They can get pulmonary emboli or thrombi, and they also are at risk, of course, for tissue breakdown and susceptibility to infection. From a respiratory standpoint, these kids that are immobilized will have a decreased need for oxygen, diminished vital capacity, poor abdominal tone and abdominal distension. They can have mechanical or biochemical secretion retention and loss of respiratory muscle strength. There's a great table on pages 1051 to 1053 in your book, table 31-1, that kind of reviews these things. Continuing in the GI system, these kids can have distension caused by poor abdominal or muscle tone, difficulty feeding in a prone position. Imagine having to eat, either laying on your face or even in a supine position if they can't sit up. Constipation, anorexia, and decreased appetite. From a skin perspective, we have already touched on this a little bit, but they'll have decreased circulation and pressure, leading to decreased healing capacity. There's actually a Braden scale for children. It's called the Modified Braden Q Scale, and I definitely want you to Google that. Look at it, get a general knowledge of how it's a little bit different than the Braden scale for adults. This modified Braden Q scale is for children who are acutely ill or who are at risk for skin breakdown from neurologic conditions and immobilization. From a urinary system standpoint, they can have difficulty voiding, of course. If they're in the supine position, they can get urinary retention, and of course that can lead to infection. Continuing with the general effects, they will have diminished environmental stimuli, and sensory deprivation, especially for kids, can lead to feelings of isolation and boredom, of being forgotten, especially by their peers. They can have an altered perception of their self and the environment. They can have increased feelings of frustration, helplessness, anxiety. They can be depressed, get angry, show aggressive behavior. They can have developmental regression, especially depending on the age of the child. The kids can actually start reverting back developmentally speaking and maybe become incontinent again, or want their pacifier, or just want their mom or dad, those kinds of things. Effects on families with extended periods of immobilization. Obviously, logistically managing a sick child, especially if both parents work, that can definitely put a strain on things. And so they're going to need family support and possibly some home care assistance. And we're also going to be needing to assess this family and this child's coping skills. Do they have the proper skills to cope with whatever's going on with their child? Traumatic injury, again, very similar in kids as it is in adults. Soft tissue injury are injuries to your muscles, ligaments, and tendons, usually come from sports or mishaps during play. And this just gives you a picture of some of the sites of injuries to bones, joints, and soft tissues. Contusions are damage to soft tissue or subcu tissue and muscle, and it's an escape of blood into the tissues, ecchymosis or bruising, and it causes that black and blue discoloration. It can lead to swelling, pain, and disability. What we do for these with kiddos is cold application, of course. Remember myositis ossificans, I think we talked about this a little bit, and this is the result of impact which causes damage to the sheath that surrounds the bone, which is the periosteum, and then the bone starts to grow within the muscle and it causes pain, usually 2 to 4 weeks after the injury occurs, and then it actually becomes mature bone in 3 to 6 months. So very important, especially if a child is kicked by a horse or has a very blunt, hard contusion, if they're playing soccer or something of that nature, to monitor and make sure that that periosteum has not been damaged and make sure that we don't have this occurring, this myositis ossificans. Dislocations, of course, occur when the force of stress on a ligament is sufficient to displace the normal position of opposing bone ends or bone ends to the socket. Pain, of course, is going to increase with activity or even passive movement of the affected extremity. Down syndrome kiddos are more susceptible to dislocations. And then hip dislocation, obviously the potential loss of blood supply to the head of the femur can be a medical emergency. Children younger than 5 can dislocate their hips simply by falling. And relocation of the hip within 1 hour provides the best chance for prevention of damage to the femoral head, because we definitely don't want loss of blood supply to that femoral head. The most common type of dislocation in children is of the phalanges, followed by the elbow. So first the fingers is the most common, and then of course the elbow. A lot of times parents will be holding the child's hand and kind of jerk them a certain way, or 1, 2, 3, we. I know my kids love this game, dad on one side, mom on the other, and you swing the child, and that absolutely is not good for the elbows and the joints and can cause dislocations. Sprains and strains, again, very similar as in adults. A sprain is trauma to a joint from a ligament partially or completely torn or stretched by a force. It may have associated damage to the blood vessels, muscles, tendons, and nerves. It has rapid onset of swelling with disability and pain, of course. A strain is a microscopic musculotendinous tear. It's similar to a sprain. The area will be swollen, painful to the touch, and the strains generally occur over time. It's not one instant where it happens like a sprain. This is something where they're straining over a period of time. Therapeutic management of these soft tissue injuries, again, really no change here from the adult side. RICE, rest, ice, compression, and elevation, and ISIS, another acronym to help you remember. Rest the injured part, ice immediately, maximum of 30 minutes at a time. A wet elastic bandage for compression. You want to elevate the extremity. You want to immobilize and support the extremity. You can use casts or splints as appropriate and, of course, as ordered by the physician. Fractures. In children, fractures heal much faster than in adults. They are common injury in children. Methods of treatment are different in pediatrics than in the older adult population. Fractures are rare in infants, except when a motor vehicle crash is involved. The clavicle is the most frequently broken bone in childhood, especially in those less than 10 years old. And many of those are from falling off of a bunk bed. There's actually warning labels on bunk beds. And I believe they say not for children under 10, or it might be under 12. I haven't read one in a while, but that's usually the most common clavicle break. Obviously, school-age children, you'll see bike and sports injuries. Anytime you have a small child that shows X-ray evidence of fractures at various stages of healing, with very few exceptions, those are the result of non-accidental trauma or abuse. Now, you do have to be careful because You definitely, any investigation of multiple fractures at different stages of healing should include consideration of osteogenesis imperfecta, which is a genetic disorder that's characterized by bones that break easily, often from very little or no apparent cause. But once that is ruled out, then definitely abuse is the next thing that we look at, unfortunately. The growth plate or physial plate injury, this is the weakest point of the long bone. It is the cartilage growth plate or the epiphyseal plate. It is a frequent site of damage during trauma. It can affect future bone growth, so it's very important if the child has a break at this plate during their growing years. Treatment may include open reduction internal fixation to prevent growth disturbances. So a lot of times when kids fracture along the epiphyseal plate of a long bone, they will more than likely have surgery to fix it simply to make sure their growth does not get affected. Types of fractures, this is no different than in adults. Compound or open, obviously the fracture bone protrudes through the skin. Complicated bone fragments have damaged other organs or tissues. Comminuted is kind of where it's shattered. You have all those small fragments of bone broken from the fractured shaft and they lie in the surrounding tissue. And green stick, compressed side of the bone bends, but the tension side of the bone breaks, causing an incomplete fracture. And here's just some pictures. Now this plastic deformation, remember, kids' bones are soft. So in a child, you can have a plastic deformation where the bone just bends but does not break. So that is a little bit different. You don't see those in adults. Obviously, an adult bone would break. And here you see a bone that has a complete fracture but has a periosteal hinge, meaning that obviously the periosteum was destroyed or disrupted on this side, but on this side the periosteum remains intact and acts like a hinge, which is a good thing, right? Because periosteum means we have good blood supply here. So once they get this back together, this fracture would heal a little better just simply because this side of the periosteum has not been disrupted. Bone healing and remodeling in kids, it's rapid in children because their periosteums are thicker and they have a really good blood supply. So neonatal fractures, 2 to 3 weeks you're looking at for healing time. Early childhood, 4 weeks. Later childhood, 6 to 8 weeks. And adolescence, 8 to 12 weeks. And if you go back and kind of compare this to your adult values, you'll see that it is definitely quicker. How do we diagnose a fracture? Obviously, X-ray is the most useful diagnostic tool. What are our therapeutic management goals and our nursing care management? Our goals of fracture management are, number 1, regain alignment and length of the bony fragments, which is reduction. Number 2, we want to retain alignment and length, and we do that through immobilization. Number 3, we want to restore function to the injured parts and hopefully back to their prior level of functioning, especially in a child. And number 4, we want to prevent further injury. So there are 4 goals of fracture management. This is also not any different. Your neurovascular assessment, your 6 Ps, your pain, pulselessness distal to the fracture site, pallor, paresthesia, paralysis, and pressure. And paralysis, we're looking at movement distally to the fracture site. And of course, pressure, we're looking at swelling or edema. So your neurovascular assessment video would be great to review also because that is no different in a child. So the child in a cast, there are 4 major categories of cast. There's an upper extremity cast, a lower extremity cast, a spinal cervical cast, or a spica cast. The spica cast will immobilize the hip and the knee. This little guy here has on an upper extremity cast, of course. Cast care at home, obviously same as with an adult, observing for the 6 Ps. The difference here is you have to make sure the child does not put anything under the cast. Obviously we have that issue with some adults as well, but we're talking about kids. So making sure they understand that they're not to put anything in the cast. Cast removal, if you've ever seen a cast cut or had a cast cut off, the cast saw makes a noise just like a saw, and you see a blade. So cast removal for a kid can be very frightening because it looks like, to them, it's like you're cutting off their extremity, especially to, if the cast has been in place for a very lengthy period of time, you want to warn the parent and the child that they're going to have decreased muscle mass, and their skin will be dry and flaky. So kind of warn them of all those things before you remove the cast, so when you take the cast off and you open that up, they're not frightened by any of that. Obviously, you're going to explain to them that warm sensation and vibration is what they're going to feel when the cast saw is used, and that's normal. And then for the skincare, obviously, they can utilize some lotion or an oil after that cast is removed to help that skin rejuvenate for them. If you've not seen the cast cutter, we do have one on the ortho unit. So remind me when you're on the unit and I can show you where our cast cutter is. So here's just a quick little audience response question. Which of the following would be the most appropriate play activity for a 3-year-old child in a spica cast? Remember, spica goes around the waist, the abdominal area, and all the way down the leg, one or both legs, considering both safety and development. And the answer to this question is playing with a toy telephone. Definitely don't want marbles, checkers, or crayons, because those can all be things that are put down a cast. Older infants and small children can stuff bits of food and sometimes toys in the cast. So parents need to be alerted to this possibility. 3-year-olds are too young for checkers, and checkers could be placed in the cast. And then crayons are also developmentally appropriate, but could be placed in the cast. Can you imagine putting food down there, how that would smell after a few days? Traction. We have talked about this. We can have traction in children just as in adults. The purpose of traction is to fatigue the involved muscles, which then in turn reduces muscle spasm so that the bones can be aligned. We want to position those bone ends to promote healing. We want to immobilize the fracture site until healing is sufficient to permit casting or splinting. We want to help prevent or improve contracture deformity, and we want to provide immobilization of specific areas of the body, and then of course reducing muscle spasms, which muscle spasms are actually rare in children, but we definitely want to still reduce them if that's going to be an issue. Bone alignment, this is a really good picture that really talks about the counter traction and the traction, the line of pull and the fracture site. There are 3 essential components of traction. 3 essential components of traction management are the traction, which is the forward force, so that's down here, the forward force on the bone, the counter traction, which is the backward force, and then the friction, which is the patient's contact with the bed. So the fact that their weight is on the bed with the traction, the forward force, and the counter traction, the backward force, those are all the components that go into fracture management. I should say traction management for fractures. Types of traction, same as with adults. We have manual traction, which is applied to the body part by the hand, placed distally to the fracture site. It's used during an application of a cast or with closed reduction, and you may assist the physician with this. This is not something you would ever do by yourself, but the physician would ask you to apply some traction. He'll tell you exactly what to do and what way to pull while he either casts something or pops something back in place if we're doing a closed reduction. Skin traction, there's Bryant traction, and there's a picture on the next slide. This is Bryant's traction. It's for congenital hip dysplasias. So you see the little kiddo these are the weights and the pulleys, and that's the traction there, and that's Bryant's traction. Their legs are flexed at 90-degree angle at their hips with their buttocks raised slightly off the bed. Can you imagine a child staying in that exact position? Buck's extension. The leg is in the extended position, short term, that's usually for pre-op. And then of course skeletal traction, where we apply directly to the skeletal structure with pins, wires, or tongs inserted into or through the diameter of the bone distal to the fracture. So that would be like an external fixation or internal fixation device. Again, Bryant traction for congenital hip dysplasias or femur fractures. And you see that little girl just laying there so nice and quiet and still, and I'm sure that that lasted all of 3 seconds, so if you can imagine. Cervical traction. There are 2 different types of cervical traction. There is the halo brace or halo vest, and that's how most cervical traction is accomplished. And then there are also Gardner-Wells tongs or Crutchfield tongs, and you will see those sometimes also. Figure 31-10A on page 1064 in your book has a picture of the halo brace or halo vest. And then Gardner-Wells tongs or Crutchfield tongs, these are inserted through burr holes in the skull with weights attached to the hyperextended head. Figure 31-10B on page 1064 shows you a picture of these. What happens then is the neck muscles fatigue with the constant traction or pull, and the vertebral bodies gradually separate, so the spinal cord is no longer pinched between the vertebrae. So that's what happens with the Gardner-Wells tongs. Again, here's a picture. Picture A is a picture of your Gardner-Wells, and picture B is a picture of the halo. Now remember, with the halo, the pin sites are inserted right into the skull, so you have pin site care to do. And with Gardner-Wells, the end of these here are where your pins are inserted, and so you'll have pin site care to do there also. Remember, with the halo, with both of these, but especially with the halo because that's what we see more frequently in this area, pressure points on this harness. First of all, this is a very heavy contraption, and so you need to be assessing the shoulders under here, anywhere that this might be tight, the abdomen, the back, the scapula. Any of those areas can cause pressure. This particular one is very nicely padded. We don't usually see a lot of that kind of padding for adults. Now, I don't know what they look like for kids because we usually don't see kids in halos down here. Nursing care management for traction, of course, to assess them. Remember, the weights need to hang freely at all times. The only time you move those weights is if you are repositioning the patient. Do not release or lift those traction weights, again, unless you're repositioning or you have an order to do so. You want to maintain alignment, of course. You want to prevent skin breakdown, prevent complications such as atelectasis, nutritional deficiencies. I mean, there's just a myriad of complications that can occur, kind of back to those first few slides of all the physiological effects of immobilization. Pain management and comfort, of course, these are going to be also critical for your patient. These are kids. They're not going to be comfortable staying in one spot or not moving about like they want to. There's a great box in your book, the nursing care guidelines for traction care in Wong on page 1065. So definitely take a look at that. How do we assess pain for kids? There's many different ways. This particular one is the Wong-Baker Faces pain scale. So in this pain scale, you show the child these faces and you read to them what each of the faces represent, and then you ask them to point to one of the faces to tell you how much pain they're in. So Wong-Baker Faces pain scale is an option. This is another verbalization of pain, how they feel. Again, you can read these, show them the faces, and see if you can glean what kind of pain or feeling they're having. The FLAC pain scale really looks at maybe a child who is not able to speak, not able to point to a face. So you're looking at their face, their legs, their activity, their crying, and are they consolable or not? And then you come up with a score, and then that is your pain score. So there's various ways to assess pain for children. Amputation, something we should never have to talk about for kids, but it definitely happens. Surgical amputation can occur due to bone cancer or osteosarcomas. There can be surgical repair of a severed limb if a child, I've heard of many lawnmower accidents with children. Obviously, prosthetics definitely play a role. And then, of course, pain management, just like for adults, they will have that phantom limb pain just like adults do. If you are in a situation where you have a child that traumatically loses a limb, we want to preserve that until we can get it to the hospital. So you definitely want to do as best you can to preserve that limb for the best chance of reattachment. So you want to rinse the limb gently with normal saline. You want to loosely wrap it in some sterile gauze, place it in a watertight bag, cool cool it in some ice water, but yet don't freeze it. And you want to label it with their name, date, and time. Now, do you have all this equipment in your vehicle or on your person at all times? Absolutely not. But this is a guideline for you. So if you can do the best you can with what you have, knowing the guideline, knowing the perfect scenario, you're still going to give that limb the best chance you can for reattachment. You know, maybe you have a bottle of water in your car. Maybe you have a new shirt, you just bought it at Kohl's or something. You know, obviously use what you have to do the best you can, knowing what the perfect scenario would be. Birth and developmental defects. The one big, there's a lot of things here, but the big thing we're going to talk about is developmental dysplasia of the hip, or DDH as it is abbreviated. It can be idiopathic or tetralogic. It is a neuromuscular defect that occurs in utero. It was formerly called congenital hip dysplasia or congenital dislocation of the hip. DDH reflects a variety of hip abnormalities. So they have a shallow acetabulum, subluxation, and dislocation, or dislocation. The predisposing factors of DDH there are 3 of them. They're physiologic factors, mechanical factors such as a breech presentation, multiple fetuses, oligohydramnios, which is too little amniotic fluid, and a large infant size, continued maintenance of the hips in adduction and extension that over time will cause dislocation. And then the third predisposing factor is genetic factors. 60% of DDH is the left hip and 60% are girls. 3 degrees of DDH. The acetabular dysplasia or preluxation is the mildest form. So the femoral head actually remains in the acetabulum, but it is definitely has the dysplasia, the acetabular dysplasia, but it's very mild. Subluxation is incomplete dislocation of the hip, and then dislocation, the femoral head completely loses contact with the acetabulum and is displaced posteriorly and superiorly. The ligaments become elongated and taut. And I believe there's a really good picture in your book of the differences. Page 1068 actually in your book shows you these different degrees of DDH. What are we doing for these kiddos? Early intervention is critical. So if they're newborn to age 6 months and we find it, they're going to do a Pavlik harness for abduction of the hip. Figure 31-15 on page 1070 shows you what a Pavlik harness looks like. If we don't catch it till 6 to 24 months, the dislocation goes unrecognized until the child begins to stand and walk. Then we're going to have to do a closed reduction and a spica cast for 12 weeks. That's huge. I mean, that's surgery. Even though we're not cutting, they're going to put that kiddo out to do the closed reduction, and then having to wear that spica for 12 weeks is obviously very limiting. Older children, they're going to have surgery. So they're going to have to go in, do an open reduction internal fixation. They're going to be casted. And anytime after the age of 4, it's very, very difficult to correct this. So that is why it's so critical, and those of you who have had children know when you bring them to the doctor, they do all these tests and they crank those hips out, and that's what they're checking for. They're checking for DDH because the sooner we catch it, the less invasive things we have to do to correct it. So in an infant, what DDH is going to look like is the shortened limb on the affected side. So you'll see in figure A, Figure A actually shows asymmetry of the gluteal and thigh folds with shortening of the thigh. So if you look, you can see that these, just by holding that baby up and letting them dangle, you can see the difference in their legs there. Restricted abduction of the hip on the affected side. So B shows limited hip abduction. You see that B is not letting that doctor crank that hip all the way out. It's not going. He's meeting resistance there. Asymmetric thigh and gluteal folds, we talked about that. Positive ortolani test, that shows in figure D. The femoral head moves in and out of the acetabulum in infants 1 to 2 months old. So you can see here, they're testing for that, moving in and out of the acetabulum. And then the positive Barlow test, is another test that they use. And then look at figure E here. You see the positive Trendelenburg sign with lordosis. So if the child's old enough, you can see the lordosis of the lumbar spine when they hold on to something and pull their foot up. Then you can tell from the back. But hopefully we have caught this way back here so this poor child doesn't have to undergo surgery. Picture C shows apparent shortening of the femur as indicated by the level of the knees in flexion. That's called the Alice sign. So you can see that their knees aren't the same height because the femur is shortened on the affected side. So just know generally about these tests. And again, if you've had kids, you've seen your doctor do these. And if you've been a new mom, you're like, what is this doctor doing to my child? Well, that's what they're doing. They're checking for DDH because we want to catch it early. Clubfoot. Clubfoot is a deformity of the ankle and foot. You can see inversion or bending inward. You can see eversion or bending outward. You can see plantar flexion with toes lower than the heel. You can see dorsiflexion with toes higher than the heel. Or you can see a combination, which are toes lower than the heel and facing inward, and that is actually the most common. It can be positional, so it could have been something in utero, and those types usually correct spontaneously or just some exercises or even some serial casting to get them back into the correct shape. They can be syndromic, which means they are associated with other congenital abnormalities. These require surgical correction and have a high incidence of recurrence. They can be congenital, where the bony abnormality almost always requires surgical intervention. If the child is 6 or more weeks, if after 6 or more weeks of stretching and serial casting, then we're going to consider surgery for these kiddos. This combination one is called TEV, which is Talipes equinovarus, and that is actually 95% of the clubfoot cases. Figure 31-16 on page 1071 in your book shows you some pictures of these. What are we going to do to manage this? Serial casting begun shortly after birth. So what they do is weekly they will gently manipulate the feet and then cast them in the position they want them to be. So what it's like is it's like passive range of motion with casts. So you passively move that a little bit and then you hurry up and cast it and it'll stay in that position. Then they come back, you take that cast off, and now you move it a little more in the direction you want it to go and cast it again. So it's quite involved. If that's unsuccessful, these kiddos are going to need surgical intervention. Obviously, skin assessment is huge if you're doing serial casting, and good patient and caregiver teaching. Neurovascular assessment, of course, your 6Ps, and patient and caregiver teaching for that also. We want moms and dads and babysitters and grandmas and grandpas to know what to look for to help prevent any neurovascular compromise. So education for parents is huge. So the treatment of clubfoot is 3 stages. We want to correct the deformity. That's number 1. We want to maintain the correction until normal muscle balance is regained. That's number 2. And finally, number 3, we want to follow up and observe to avert any possible reoccurrence. So correct, maintain, and follow up. Those are the 3 stages of treatment with clubfoot. And if you think about the muscle balance, so if I have clubfoot and my muscles are used to being in a certain position, and now I've utilized serial casting, it's going to take a while for that muscle memory to change, if you would, back to what normal muscle memory should be, because the muscle memory is so used to being the abnormal way, and now we have caused it to be normal again, and so it's going to take a while for those muscles to remember that and maintain that. Here's a picture of a cute little person, and this person has bilateral Talipes equinovarus. Remember, that's the one that is in 95% of the cases. And so it's a combination. Their toes are lower than their heel, facing inward, and it's the most common, remember. And so we've got some serial casting going on then here. And you see right now the toes are still lower than the heel, but every time they recast this little guy or girl, they're going to bring those toes up to help correct that. Okay, moving on to leg calf Perthes disease. This is a self-limiting disease affecting children ages 2 to 12, most common in males ages 4 to 8. Aseptic or avascular necrosis of the femoral head is what we're looking at here, which is a bad thing. 10% of the cases have bilateral hip involvement. Most have a skeletal age below their chronological age, sorry. And the pathophys on this, we really don't know the cause, but we do know that it involves disturbed circulation to the femoral head with ischemic aseptic necrosis. So this can definitely be a huge issue for these kiddos. What are we going to see? Typically, the patients that have leg calf perthes are going to present with knee pain, hip pain, they're going to ambulate with a limp, and they're going to have muscle spasms. So it's going to be an insidious onset, history of the limp, soreness, stiffness, limited range of motion, a vague history of trauma, but nothing overwhelming. Their pain and limp is going to be most evident upon arising and at the end of activity. It is diagnosed by X-ray and sometimes an MRI. What are we going to do for these kids? We are going to first pull the screen down a little bit so you can see the whole slide. Oops, sorry. Let me get this here. Okay, our treatment goals are to eliminate the hip instability and ensure a well-rounded femoral head at the time of healing. They use various appliances and devices to accomplish this. At first, initially, we're going to have them rest. We're going to have them non-weight bearing initially. Sometimes surgery is required, sometimes home traction. Their prognosis, this is a self-limiting disease. The outcome has wide variations because of many, many different factors. For nursing management, we're going to identify affected children and get them the proper referrals. We're going to teach them how to care for and manage this condition and make sure that they understand how important compliance is, not only the child, but the family. Abnormal spine curves. Oh, I'm sorry, let me go back. I want to say a couple more things about leg calf perthes. Children 5 and under often get complete recovery with this condition, leg calf perthes. Children 10 and older have significant risk of degenerative arthritis. So if we don't catch these early, those kiddos really have a bigger risk of degenerative arthritis. Okay, spine curves. Figure 31-18 on page 1076 shows you the different curvatures of the spine. Obviously, this young lady has a normal spine, so you see our spine does have natural curves. Our cervical curve, then we have our thoracic, our lumbar, and our sacrum. This is scoliosis. It's the most common spinal deformity. It can be congenital or it can develop during childhood, like the adolescent years, ages 10 or later is the most common. It has multiple potential causes. Most causes are idiopathic, meaning we don't know what causes it. It generally becomes noticeable after a pre-adolescent growth spurt. And these kiddos complain of their clothes not fitting right. You'll see their shoulders, they have asymmetry of their shoulder height. So if you look at them from behind, you'll see that is asymmetrical. And then their hips are also asymmetrical if you look at that. These patients will present with imbalance at their shoulders, waist, and hips. We diagnose it with physical exam and x-rays. There are 3 types of scoliosis. Idiopathic, which is the most common, of course. There's congenital, where they have malformation of bony vertebral segments. And then there's neuromuscular or paralytic, where they actually have paralysis of the trunk muscles, sweeping scoliosis. And these are kiddos that have history of cerebral palsy or muscular dystrophy. So again, that was all with scoliosis, idiopathic, congenital, or neuromuscular paralytic. The next one we're going to look at is lordosis, and that's all the way here on the end. This is an accentuation of the cervical or lumbar curvature beyond the physiologic limit. So you see how far in that lumbar curve is now going. This can be idiopathic or secondary complication of trauma. It can occur with flexion contractures of the hip or congenital dislocated hip. If a child is obese, the abdominal fat can alter their center of gravity, causing lordosis. So if they're really heavy, this abdominal fat can pull that spine forward and cause the lordosis. How are we going to manage, let's move forward here, lordosis we just talked about, scoliosis I talked about. So how are we going to manage scoliosis? So the therapeutic management of scoliosis really is based on the degree of curvature. Bracing is one of the things we can do for these kids. It is not curative, it just slows the progression of the curvature to allow skeletal growth. Exercises can help. And then, of course, if the curvature is severe enough, we would do surgical intervention. It would be a spinal fusion, and we would realign with internal fixation and bony fusion. Obviously, post-op concerns, skin and wound assessment, neurovascular assessment, pain, ileus, adequate urinary output, and electrolyte imbalance. The treatment, of course, again, is based on the degree of curvature. If the degree is less than 20 degrees, we're just going to observe. If it's 20 to 40 degrees, the thoracocolumbo-sacral orthosis, or TLSO, will be used to prevent further curvature, and a lot of you have seen those on the ortho unit for adults. If it's greater than 40 degrees, they're going to do surgical fixation. So again, these kids are monitored throughout their childhood years to watch that degree of curvature, and that's kind of the basis of how we decide to treat. Okay, slipped capital femoral epiphysis. This is our This is posterior displacement of the proximal femoral epiphysis. We don't know why it happens. It's the most common hip disorder in adolescents. Usually boys age 10 to 17 years old and girls 8 to 15, 2 to 3 more times more likely in boys than in girls, and 25 to 50% are bilateral. How does this patient present? They present with knee or hip pain that's long-standing, they ambulate with a limp, and they have decreased motion. How are we going to diagnose this? They're going to have decreased active range of motion, internal rotation, and abduction. X-rays, their ice cream is falling off the cone. And let me see if we have a picture. Yes. So if you look, it's kind of a cool X-ray. I like it. Their ice cream's falling off the cone. So if you look here, okay, let's look at the normal one first. So here is the capital femoral epiphysis. This is the normal growth plate. You see it right here. You can kind of see that delineation. This is your femoral neck, and this is how it should look. That capital femoral epiphysis should be right on top of that femoral neck. In slipped capital femoral epiphysis, our epiphysis is sliding off of our cone. Your femoral neck is the cone, and our ice cream is falling off the cone. So we do not want our ice cream to fall off of our cone. If the child complains of knee pain at this age, 10 to 17 for boys, girls 8 to 15, you want to assess them for hip issues. It's really funny. A lot of times these kiddos will come in and they'll say, oh, my knees hurt, my knees hurt. And what is the doctor going to look at? They're going to look at their hips, and the parents are like, we didn't say their hips hurt. We said their knees hurt. And so sometimes you have to do some education there and explain, there are a lot of reasons for the knees to hurt. And one of the things we have to look at are the hips. Conservative treatment, bed rest, non-weight bearing is what we're going to do for these kiddos. And again, our ice cream scoop falling off of our cone. And here's another picture, a book picture, of course, our femur. This is our growth plate, and our scoop is falling off of our cone. It's melting. Okay, osteogenesis imperfecta. This is a horrible condition for these kiddos. This is brittle bone disease. What happens is the bones fracture with very minimal stress. It's a defect of collagen synthesis, and they will have generalized osteopenia. And we talked about this a little bit earlier in the slides. Remember, if you have X-ray evidence of fractures at various stages of healing, this would be the one other explanation besides abuse. Either one is absolutely horrible, but this would actually be a medical condition. Patient presents with thin translucent skin, short stature. Let's go back. You'll see the blue sclera. This is very indicative of a child with osteogenesis imperfecta. Shepherd crook deformity. Do you see how they almost have that a plastic deformation like we talked about earlier? They can have deafness, and they can have dentinogenesis with their teeth. So these are all signs and presentations of a child with osteogenesis imperfecta. I think I posted this online too for you in Canvas. Um, it's a genetic disorder, results from a lack of the protein collagen, which causes brittle bones that break easily. Signs can vary, range from moderate to severe. They can have a curved spine, they can have hearing loss. Um, they have a triangular shaped face, usually with a broad forehead. The whites of their eyes look blue, purple, or gray. Their teeth are brittle. They can have a barrel shaped rib cage, a small body, deformed bones. It can cause spinal curvature, such as kyphosis, which can lead to rounded or hunchback appearance. There's really no cure. Treatment involves managing the symptoms. You treat broken bones, you treat the brittle teeth, pain medications, physical therapy, use of assistive tools such as braces and wheelchairs, making sure they have a good diet, exercise, no smoking, drinking, alcohol, or caffeine. You really want to put these kiddos in a bubble and not let them do anything, but you know, on the other hand, you can't, because what kind of life is that? So it's very, very sad for these kids and families. Osteomyelitis. This is same as pretty much in adults as it is in kiddos. Infectious process in the bone. Staph aureus is the most common. Obviously, we're going to get culture and sensitivity of our aspirated, purulent, drained blood and joint fluid. That is essential for effective therapy. So remember, nurses, forever and ever, amen. Do not start any kind of antibiotic until you have orders and have obtained your culture and sensitivities. You're going to see an elevated white count, an elevated ESR, which will be supportive of the diagnosis, and MRI and bone scan is also used for diagnosis. Now, in kiddos, these can be, just like in adults, exogenous from trauma or surgery, or hematogenous, which is seeded by an organism from a pre-existing infection. So in kids, that's usually tonsillitis, impetigo. One of those secondary infections could possibly seed a case of osteo. What are we going to do for these kiddos? IV antibiotics for 3 to 4 weeks. They may need up to 4 months. We're going to monitor their hematologic, renal, hepatic side effects to that antibiotic therapy. We're going to put in a PICC line or a CVC for long-term antibiotics. We're going to make them non-weight bearing in the acute phase till we get this under control. And of course, pain management is huge for these kiddos. Septic arthritis, a bacterial infection of the joint. It may result from spread or extension of cellulitis or osteomyelitis. Staph aureus is the most common. You'll see this in knees, hips, ankles, and elbows. Those are the most common areas. It's an infection. An infection involving the hip is a surgical emergency because you want to prevent compromised blood supply to the femoral head. What are we going to do with these kiddos? We're going to make the diagnosis, of course, from our joint fluid culture or blood cultures. We're going to do a white count, an ESR, a CAT scan, and MRI. We're going to treat with antibiotic pain therapy, pain management, physical therapy, and if all that doesn't work, obviously surgical intervention. Bone tumors. Oh, let me go back just one moment. For septic arthritis, when we talk about, let me go back one more. When we talk about Staph aureus, you guys, Staph aureus is the most common, of course. And more we're seeing that it's community-acquired Staph aureus. These are the kiddos I've talked about before that are falling, scraping their knee, getting staph, and then it turning into a septic arthritis or an osteo or something awful like that. Okay, bone tumors. Osteosarcoma or osteogenic sarcoma and Ewing sarcoma account for 90% of all primary malignant bone tumors in children. They occur more commonly in boys with the highest incidence during the accelerated growth rate of adolescence. Ewing sarcoma, and this is important, Ewing sarcoma arises in the marrow spaces of the bone rather from the osseous tissue. And then rhabdomyosarcoma is malignant neoplasms that originate from cells in muscles, tendons, bursa, and fascia, or in fibrous connective tissue, lymphatic, or vascular tissue. So definitely know the difference between osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma. Those are important differences to be aware of. Osteosarcoma is the most common bone cancer in children. The peak incidence age 10 to 25. The most primary tumor sites are dimetaphyseal, which is the wider part of the shaft adjacent to the epiphyseal growth plate region of the long bones. Greater than 50% of these occur in the distal femur, but other sites do include the humerus, tibia, pelvis, and jaw. Definitive diagnosis is done by X-ray, CT, MRI, or bone scans, and needle and or surgical bone biopsy. This is a picture of an area here, so it's right above the knee you see. This is the femur, and this is kind of sectioned, so it's sliced kind of through the middle. This shows you a picture of an osteosarcoma tumor, and then this is what it actually looks like. That's a true cross section. So these are horrific, awful, awful things. What are we going to do for these? The optimum treatment is surgery. We're either going to try and salvage some of the limb, or we're going to amputate. As you can imagine in the picture I just showed you, there's nothing good that can come of that, so we need to get it out. Hopefully we can do some limb salvage procedure where we can save part of the femur, but if not, we are just going to take that entire femur out. And it is possible with a limb salvage procedure, resection of the primary tumor with prosthetic replacement of the involved bone. So it can be a total femur and joint replacement. Obviously, they're going to have some chemotherapy in addition. Our nursing concerns, preoperative preparation is crucial. Support during the adjustment to the concept of amputation and surgical resection. Remember how old these kiddos are. These are adolescent boys between the ages of like 10 and 25 years old. I mean, what other time in your life are looks and your life, your activity more important? Body image concerns, obviously, with adolescents, pain management, and phantom limb pain. But if we don't take care of this, if these aren't removed and stopped immediately, these kids can die. So, death versus removing our femur, absolutely, we're going to opt to remove the femur. Okay, juvenile idiopathic arthritis, JIA. This used to be called, AKA, juvenile rheumatoid arthritis, and they stopped calling it that because not all of these kiddos are positive with rheumatoid factor. This is a chronic autoimmune inflammatory disease. It usually starts before the age of 16. The cause is unknown. It causes chronic inflammation of the synovium with joint effusion and eventual destruction of the articular cartilage. It really is not a single disease, but it's kind of a group of diseases. Look at page 1084 in your book, and there's some good information there. JIA is a diagnosis of exclusion. There are really no definitive tests to say, yep, you're JIA positive. Lab tests might support JIA, such as an increased SED rate or an increased white blood cell count, but there's no one specific battery of tests that make this positive. What are we going to do for these kiddos? There's no specific cure. Goals of our therapy are to control pain, preserve joint range of motion and function, and minimize joint deformity. They're going to have PT and OT. We want them to exercise and get adequate nutrition. We may need some splinting devices and some pain management, of course. Medications for JIA, our first line is going to be NSAIDs, of course. If that's not working, we're going to look at methotrexate as a second line medication, and that is only used after we have failed NSAID treatment. And of course, if they're on methotrexate, we need to monitor their CBC and liver function. Corticosteroids, we're going to use these for incapacitating arthritis, but remember, prolonged use of systemic steroids has significant side effects such as Cushing's syndrome, osteoporosis, increased risk of infection, glucose intolerance, cataracts, and growth suppression. Finally, we can look at biologic agents. These actually are used to interrupt and minimize the inflammatory process. Lupus, systemic lupus erythematosus in kids. This is a chronic multisystem autoimmune disease of the connective tissues and blood vessels. It is characterized by inflammation in any body tissue. The symptoms and course are variable and unpredictable. It can be mild to life-threatening complications. It's more common in females ages 10 to 19. more common in African American, Asian, and Hispanic children. There is a familial tendency. We really don't know the cause, and there are triggers. If you look at page 1087 in your book, there's a good list of triggers there. They include exposure to UV light, estrogen, pregnancy, infections, and drugs. Lupus.org /new site /index.html. There's some available resources there for children and families. Lupus.org. Box 31-12 on page 1087 in your book show you the clinical manifestations of lupus, and box 31-13, page 1087, give you the diagnostic criteria for lupus. You have to meet 4 of the 11 criteria. If our kidneys become involved, that heralds progressive disease and requires rigorous management. So if you have kidney involvement, that's not good, and we really have to be on top of that and be managing this very, very closely. This is a picture of the well-known butterfly rash that accompanies lupus in kids and in adults. This is a great picture of that rash. This talks about the most common symptoms of SLE, including low-grade fever, photosensitivity, mouth and nose ulcers, muscle aches, joint aches, and arthritis, fatigue, loss of appetite, the butterfly rash, which we've already talked about, inflammation of the pleura or lining of the lungs, inflammation of your pericardium, poor circulation in your fingers and toes. It's just a multitude of symptoms, and these people just feel awful. These kiddos are very sick. What are we going to do? General supportive care, good nutrition, rest, and exercise are key. In addition, we can support these kiddos with corticosteroids to control the inflammation. Antimalarials is useful for rash and arthritis. NSAIDs are useful for muscle and joint inflammation. And then finally, immunosuppressive agents will also help. Antihypertensives, aspirin, antibiotics are a few of the additional drugs that may be necessary to help treat or avoid flare-ups of SLE. And that is all for Chapter 31 in the Wong book. Thank you very much.